Now we have a very interesting X-ray of the abdomen erect, which was very typical finding. Now you can simply pause the video and you can try to find out what is the problem in this. Now when we try to find out what we can see, this is a very typical X-ray of abdomen erect showing multiple air fluid levels. Now what is this multiple air fluid levels is whenever there is any cavity which has air as well as fluid. So because the patient is in standing position, the patient's legs are here, this is erect abdomen, means the patient is standing and this is the head towards this area. So the fluid will basically get accumulated and it will show a transverse level which will be completely transverse, and as there is air inside that cavity, the air will be seen on the upper part. So air will be above and there will be one transverse line below which there will be accumulation of fluid. So this is called air fluid level. When we see in this X-ray abdomen erect, we can very clearly see that this is a complete horizontal line suggestive of there is the fluid or liquid in this area, and this is all air. So the air is above and the fluid is there. We have multiple such air fluid levels, which is one is here. So this is basically a fluid level and this is all the air present. So this is first, this is second, this is third. If you see here closely, this is air fluid level. So this is fluid level because you have horizontal line, and this is all air. This is all in actually small intestine because we know we have large, this is the right side of the body, this is the left side of the body. So we know we have the ascending colon which is placed in this area towards the right side. We have transverse colon which is placed in this area, and we have this descending colon placed in this left sided abdomen area, and the central part is all of small intestine. There are other things which differentiates the small intestine and large intestine. A small intestine usually have this spring type appearance. This spring type appearance which we can very clearly notice in this area. Just see, you have this spring type appearance which tells this is a small intestine part, whereas the large intestine usually have hostrations. Hostrations means basically you don't have this spring coil type of appearance of large intestine, but what we have is the larger, this type of finding or this type of anatomy. This we call it as hostrations, and this suggests large intestine and not small intestine. So, and this type of spring coil appearance is seen in small intestine. So this is a very typical erect abdomen X-ray showing multiple air fluid levels. So we have to have at least three air fluid levels to call it as intestinal obstruction. So in this we have this one, second, three, four. We have here, it is a fifth. We have here, see, if you see here, this is like this is fifth. This is sixth. So we have multiple air fluid levels suggestive of intestinal obstruction. Now, the most important thing in any intestinal obstruction is putting a Ryle's tube, because as there is obstruction of the gut, the food which comes from stomach, from the mouth, esophagus, stomach, duodenum, small intestine, large intestine, and then it goes to rectum and outside. Because of the obstruction anywhere, the stool or the food will not pass down. So it will be all accumulated in this area. And as this is accumulated, this food, feces, basically it contains huge number of bacteria. So these bacteria will grow and grow and grow, and patients lands up in a very bad sepsis. So what we do, we put a Riles tube. As soon as we put a Riles tube, all this feces, food, particle, liquid, which is all accumulated in the gut, simply is drained outside because of the Riles tube. On this, the pressure the pressure of accumulated feces, food, liquid, everything simply gets markedly better, and this intestinal obstruction can get better on its own without any surgery. So putting a Riles tube is very important. The second most important thing is hydration. As we know, these patients, they don't have appetite. They are not taking anything orally, because if you are taking anything orally, it is again going to increase the abdominal distension, feces, water, and everything. So these patients very commonly are very dehydrated, and as there is significant amount of bacteria accumulated growing very fast, these patients may land up in sepsis very fast. So to maintain the blood pressure, to maintain the hydration, to effectively kill these all bacteria, hydration is very important. That is the reason why these patients may need around 3 to 4 liters of IV fluids. So most of the patients will be on like 120 or to 150 ml per hour IV fluids. So most important thing is Riles tube insertion, hydration. Third most important thing is antibiotics, because as these patients have this accumulated feces, water, liquid, and huge number of bacteria, these patients may very badly land up in sepsis. So these patients are very commonly put on ceftriaxone or cefotaxime or piperacillin-tazobactam or meropenem or levofloxacin, metro. They can be in combination, or there can be one or two antibiotics. It totally depends on the treating surgeon. So this is a very, very typical X-ray of intestinal obstruction. The intestinal obstruction can be spontaneous, or it can be because of drug-induced. Anticholinergic medicines can also cause intestinal obstruction. One of the most common reason is adhesions. Any patient who has undergone any surgery in the past, it can be appendectomy, it can be any gastric outlet syndrome, it can be exploratory laparotomy, any abdominal surgery. Whenever a patient undergoes a surgery, then it may create adhesions. Because adhesions are all fibrotic bands. So these fibrotic bands can simply hold the small intestine or large intestine, and it can impair the motility of this, or it can completely choke up this small or large intestine, causing intestinal obstruction. So in such patients, laparotomy and adenolysis is usually indicated. So most of the medical intestinal obstructions usually get better only with Ryle's tube insertion, hydration, antibiotics, and supportive care. If it doesn't get better within 48 hours, then usually surgery is indicated. Or if the patient is very unstable, in very bad sepsis, worsening, and if it seems that this traditional therapy is not helping, or there are adhesions of the patient has multiple earlier surgeries causing this intestinal obstruction, then definitely adenolysis and the surgery is required. So this is all about in shortly about this very typical of intestinal obstruction with multiple air fluid levels, which has to be at least more than 3 air fluid levels. Thank you.